So next heading is histological findings. See, this is the normal epidermis. Okay, so this is the diagrammatic representation of normal epidermis. So normally you will find these keratinocytes gradually as you are moving upwards, they are becoming flat, they are changing their shape. Like you can see, they are columnar here, then they have become slightly polygonal here, then they have become slightly flat, spindle shaped here, and gradually they are becoming flat. Okay, so this is the normal histology. Normally you will find these changes. Here you will find prominent nucleus, then gradually smaller nucleus, and then the nucleus is absent here. So this is the normal epidermis. Okay, now in this normal epidermis, if you find certain changes, that is abnormal, and that is abnormal histological findings, which we are going to discuss. So first histological finding here is parakeratosis. Parakeratosis. What is parakeratosis? Parakeratosis is retention of nucleus in stratum corneum. Retention of nucleus in stratum corneum. Okay, so normally nucleus is absent in stratum corneum, but if you find nucleus retained in stratum corneum, that is parakeratosis. Okay, and parakeratosis can be seen in so many conditions. Like, this is a very simple mnemonic to remember it. It can be seen in P's, that is psoriasis, eczema, actinic keratosis, seborrheic dermatitis, and squamous cell carcinoma. So this is a very simple mnemonic to remember, that is P's. Okay, so psoriasis, eczema, actinic keratosis, seborrheic dermatitis, and squamous cell carcinoma. These are the conditions where you will find what? Parakeratosis, that is retention of nucleus in stratum corneum. Now let us write down one important fact here about actinic keratosis. So these are two conditions. Actinic keratosis and seborrheic keratosis. See, this is seborrheic dermatitis here, not seborrheic keratosis. This is a separate condition. Okay, and this is actinic keratosis. So remember, it is actinic keratosis and seborrheic dermatitis, not seborrheic keratosis. While here in important facts, we are discussing these two conditions, that is actinic keratosis and seborrheic keratosis. Now the points to remember here is that actinic keratosis is a pre-malignant condition. This is a pre-malignant condition, while this is a benign condition. This is a benign condition. This presents with scaly, erythematous lesions over sun-exposed areas. Do you know the meaning of this term actinic? Actinic term is used when the lesions are present over sun-exposed sites, like actinic LP occur over sun-exposed sites. Similarly, actinic keratosis also occurs over sun-exposed sites. So scaly erythematous lesions over sun-exposed areas, while seborrheic keratosis, these lesions have characteristic stuck on appearance. So these lesions have a stuck on appearance. Already this question have been asked. Stuck on appearance is seen in, it is seborrheic keratosis. So these lesions, when you will see over skin, you will find that they appear as if they are stuck over the skin from outside. Okay, so this gives stuck on appearance. In the treatment of actinic keratosis, we use topical 5-fluorouracil, imiquimod, later on we will be discussing imiquimod in warts also. This is, so mechanism of action, this is toll-like receptor (7 and 8). So it acts on toll-like receptors 7 and 8. Okay. Another treatment which is used for this pre-malignant condition, that is actinic keratosis, is photodynamic therapy. Photodynamic therapy. So photodynamic therapy, PDT, photodynamic therapy. And once question was asked on photodynamic therapy in AIIMS, and the question was that what is the color change which is seen in the lesions of actinic keratosis or any condition where photodynamic therapy is used after PDT, that is photodynamic therapy. So what is the color change which is seen in the lesions after photodynamic therapy? They become black, they become white, they become red, there is no color change. Okay, so let us try to understand that what we do in photodynamic therapy. Let us consider this is the lesion of actinic keratosis. Over this actinic keratosis lesion, we apply aminolevulinic acid. Okay, and then we show laser light. Okay, and what happens due to it? So first we apply aminolevulinic acid, then we expose it to laser light. This leads to formation of protoporphyrin 9, which is red in color and cytotoxic, leading to destruction of pre-malignant cells. So I hope you understand what is happening here, that there is a pre-malignant lesion, you have applied aminolevulinic acid over that lesion. This aminolevulinic acid is absorbed by these highly proliferative or pre-malignant cells, and when we expose it to the laser light, it gets converted to protoporphyrin 9, and this protoporphyrin 9 is cytotoxic to these cells, and this leads to destruction of these pre-malignant cells, and that's why the lesion get rid of these cells. Okay, so when there is destruction, what happens? This protoporphyrin 9 is released, and because of the release of this porphyrin, which is red in color, the lesions appear red in color, and that was the answer, that is the lesions appear red. Okay. Now if we talk about the treatment of seborrheic keratosis, it is a benign condition. Because it is a benign condition, no need for treatment, they can stay as such, but if for cosmetic reason you want to remove them, you can do electrocautery or radio frequency, you can remove them by this, or simply you can excise them. Generally excision is not required because these are the benign lesions. You can simply remove them by electrocautery and radio frequency. One important fact which you need to remember about seborrheic keratosis is that there is a sign known as laser trillet sign. Now what is laser trillet sign? So remember, numerous appearance of seborrheic keratosis lesions. So sudden numerous appearance of seborrheic keratosis lesions due to some underlying malignancy. Due to some underlying malignancy is known as laser trillet sign. Okay, so you might have read about this sign in surgery, that some patients who have underlying malignancy, they start developing sudden and numerous appearance of these seborrheic keratosis lesions. This is known as laser trillet sign, and this underlying malignancy is generally gastric adenocarcinoma. So sudden numerous appearance of seborrheic keratosis lesions due to underlying malignancy, in bracket you can write on gastric adenocarcinoma. Okay, so these are few points which you can remember about these two conditions, actinic keratosis and seborrheic keratosis. Let us move on to the second histological finding, which is dyskeratosis. Dyskeratosis is abnormal keratinization. Abnormal keratinization below stratum granulosum. Below stratum granulosum. Abnormal keratinization. So abnormal keratinization below stratum granulosum. Okay. So normally the keratinocytes are moving upwards and they are sloughing off. This is a normal keratinization process, but if there is some change or some abnormality, that is known as dyskeratosis. Okay, this is generally seen in malignant conditions. So examples are squamous cell carcinoma, It can be seen in pre-malignant condition like Bowen's disease. It can be seen in benign conditions like Hailey-Hailey disease and diarrhea disease. Now already question have been asked on diarrhea disease, so never forget this. So remember D for D. Dyskeratosis is seen in diarrhea's disease. Okay. So other examples are squamous cell carcinoma, Bowen's disease, Hailey-Hailey disease. It is also seen in diarrhea disease. Now when dyskeratosis occurs in diarrhea's disease, what happens? Two specific features are seen. You can write down separately. That is corpse grains, corpse rods. Just now I will tell you what are these. Corpse grains are generally seen in upper epidermis. Corpse rods are seen in lower epidermis. Let us consider this is epidermis. Okay, so let us consider this is epidermis. In epidermis, what is happening? Normally, the keratinocytes are being formed in stratum basale and they are gradually moving upwards. They have their specific shape, like they can be columnar, they can be polygonal, they can be spindle shaped. But due to abnormal keratinization, due to this dyskeratosis, sometimes abnormal cells are seen, and these abnormal cells can be transversely elongated keratinocytes or vertically elongated keratinocytes. These transversely elongated keratinocytes, which are generally seen in upper epidermis, are known as corpse grains, and these vertically elongated keratinocytes, which are present in lower epidermis, are known as corpse rods. And both these are features which are seen in diarrhea disease. So both these are the features of diarrhea's disease, where in upper epidermis you might find transversely elongated, and in lower epidermis you might find vertically elongated keratinocytes. Okay, if you find it difficult to remember, this is very easy to remember, because can you tell me which one comes alphabetically first, G or R? G. So this is present in upper epidermis, R comes later, so this is present in lower epidermis. This is grains. From the name itself it is suggestive. Grains like wheat grain, rice grain. If you keep them over table, how they appear? They appear transversely elongated. And rods, how we hold them? We hold them vertical. So with rod you can remember these are vertical. Okay, simple. And third is spongiosis. Spongiosis is extracellular accumulation of fluid in stratum spinosum. So extracellular accumulation of fluid in stratum spinosum, this is known as spongiosis. This is seen in acute eczema. Okay. Sometimes in acute eczema, one more finding is seen, histological finding, and that is known as ballooning. And ballooning is intracellular accumulation of fluid in stratum spinosum. Okay. So the only difference is, if it is extracellular accumulation, it is seen in, it is spongiosis. If it is intracellular accumulation, it is ballooning. Okay. Both are seen in acute eczema. Both are seen in acute eczema. Okay. Now, do you know the meaning of this term eczema? Eczema means what? Many a times patients themselves come and tell you that, doctor, I am suffering from eczema. Okay, so what is the meaning of this term eczema? Eczema means what? What they want to tell you by saying that I am suffering from eczema? What they want to tell you? What they are having? So if you go for the literal meaning of this term eczema, eczema means oozing out or boiling out. So this term eczema means boiling out or oozing out. Okay, Why? Because of the lesions of eczema which are oozing out lesions. Okay, so when you see the eczema lesions, you will find that there is some fluid which is coming out from the lesions. It appears as if the fluid is coming out from the lesions. These are oozing out lesions. These are wet lesions. Okay, so now you know that why the eczema lesions are wet. Why the fluid is coming out? Because there is extra fluid, isn't it? It might be outside the cells or it might be inside the cells. Okay, so remember, in acute eczema there is excessive fluid in the cells or outside the cells in stratum spinosum, and because this is a very itchy condition, when the patient scratch, there is breach in the topmost layer and this extra fluid in stratum spinosum leaks out, and that's why the eczema lesions are oozing out. Okay, so oozing out lesions are seen in eczema, and that's why on histology you will find spongiosis and ballooning. This we are talking about acute eczema. But in chronic eczema, acanthosis is seen. Acanthosis is thickening of stratum spinosum. So if you find thickening of stratum spinosum, that is a feature of chronic eczema. Chronic eczema. Now why? I told you eczema lesions are oozing out, but that is acute eczema. When the same eczema lesion persists for many months and years, it becomes chronic. And when it is chronic, what happens? Due to excessive scratching, the skin there have become thickened. And that thickened skin of chronic eczema is known as lichenified skin or lichenification. So chronic eczema do not present with oozing out lesions, it present with lichenified lesions. Lichenified lesions. And what is lichenification? Lichenification is characterized by three things: skin hypertrophy, increased surface markings, and pigmentary changes. So if you find these three things in a lesion, that lesion is known as lichenified lesion. Okay, so skin is thickened, there is increased surface markings and pigmentary changes, and this is a simple mnemonic to remember them, that is HMP: hypertrophy, increased markings and pigmentary changes. So if you find HMP, that is lichenified lesion, and it is very obvious because the skin is thick. When you do biopsy, again you will get what? Thick. What? Stratum spinosum. That is acanthosis. So acanthosis is seen in chronic eczema, and ballooning and spongiosis is seen in acute eczema. Now remember that in certain conditions this thickening can be regular, and in certain conditions it can be irregular. So acanthosis can be regular acanthosis, it can be irregular acanthosis. Regular acanthosis is seen in chronic eczema, also seen in psoriasis, while irregular acanthosis is seen in lichen planus. So irregular acanthosis is feature of lichen planus. Okay. Sixth is hypergranulosis. Hyper means excessive and granulosis is for stratum granulosum. So if there is thickening of stratum granulosum, that is known as hypergranulosis, and this thickening of stratum granulosum is usually seen in patients suffering from lichen planus. Now in lichen planus, this thickening of stratum granulosum is having a characteristic shape. It appears like a wedge. Okay, so this is in lichen planus, this is wedge shaped hypergranulosis. So wedge shaped hypergranulosis is seen in lichen planus. Remember this, important. Wedge shaped hypergranulosis is seen in lichen planus. Later on we will be discussing lichen planus in detail, but for now just remember that in lichen planus lesions there is a net like pattern which is seen, that is known as Wickham striae. So later on I will tell you the details in lichen planus, but for now remember that in lichen planus Wickham striae are seen, and sometimes they ask you that why Wickham striae are seen in lichen planus. This is due to this wedge shaped hypergranulosis. Okay, so Wickham striae which are seen in lichen planus are due to this histopathological finding, that is hypergranulosis in the lesions. Okay, So sometimes questions are asked, like they might ask you that irregular acanthosis with hypergranulosis is a feature of. Answer becomes lichen planus. So irregular acanthosis with hypergranulosis. Similarly, next is angranulosis. Angranulosis is absence of stratum granulosum. So in certain condition you will find absence of stratum granulosum, and this is usually seen in psoriasis and ichthyosis vulgaris. So angranulosis, that is absence of stratum granulosum, this is feature of psoriasis and ichthyosis vulgaris. So in these conditions you might find angranulosis. I told you acanthosis is also seen in psoriasis. Which type of acanthosis? Regular acanthosis. So if the question is asked that regular acanthosis with angranulosis is feature of, answer becomes psoriasis. If question is asked irregular acanthosis with hypergranulosis is feature of, answer becomes lichen planus. Okay, so remember these histological findings. Many a times these are the clue to the answer. The next is microabscess. Now this is something very, very important. So many times questions have been asked. Microabscess. See, micro means small and abscess is collection of cells. So sometimes in skin small collections of cells are seen. This is known as microabscess, and depending on the type of cell you can label them. Like if the cell is neutrophil, so a small collection of neutrophil will be known as neutrophilic microabscess. So the first one is neutrophilic microabscess. Neutrophilic, here you will find small collections of neutrophils. The example is papillary tip microabscess, which is seen in dermatitis herpetiformis. Similarly, Munro's microabscess, which is seen in psoriasis. Then Cogos pustules, they are also seen in psoriasis. Now Munro's microabscess and Cogos pustules, both are collections of neutrophils, both are seen in psoriasis. What is the difference? These are superficial, they are seen in mainly stratum corneum, while these are deep, they are mainly seen in Malpighian layer. Do you know what is Malpighian layer? Malpighian layer is lower epidermis, that is stratum spinosum along with the stratum basal, together they are known as Malpighian layer. So they are generally seen in the lower epidermis, Cogos pustules, while Munro's microabscess are generally seen in the upper epidermis, that is stratum corneum. Then second is lymphocytic microabscess. Lymphocytic, that is a small collection of lymphocytes. This is seen in Pautria's microabscess, in Mycosis fungoides. In Mycosis fungoides. Mycosis fungoides is cutaneous T-cell lymphoma, CTCL. Okay, so Pautria's microabscess, that is seen in Mycosis fungoides. It is collection of a small collection of lymphocytes. And third one is eosinophilic, that is small collections of eosinophils. Intraepidermal eosinophilic microabscess, this is seen in Pemphigus vegetans. Pemphigus vegetans is considered to be the rarest type of pemphigus. Pemphigus vegetans. Okay. So these are few microabscesses which you need to remember. So many times these questions have been asked, like already questions have been asked on Pautria's microabscess is seen in, answer is Mycosis fungoides. Similarly, eosinophilic microabscess is seen in Pemphigus vegetans. Munro's and Cogos are seen in psoriasis, and papillary tip is seen in dermatitis herpetiformis. All these are important. You need to remember all of them. Remember, first three are collections of neutrophils, Pautria's lymphocytic, and in Pemphigus vegetans, eosinophilic collections are seen. Okay. Now, since questions have been asked, so you need to remember all of them, but never forget about these two. Which two? Monro's and Poutrier's. Why? Because so many times this question have been repeated. So if you forget an examination, you can very easily recall M is seen in P and P is seen in M. That is, Monro's is seen in psoriasis and Poutrier's is seen in mycosis fungoides. So remember, M is seen in P and P is seen in M. Now there is a condition known as botryomycosis. Now this term mycosis is misnomer here because this is not a fungal infection. This is caused by Staph aureus. Now in this condition, you will find small collections of neutrophils in the center of granuloma. So in this condition, also small collections of neutrophils are seen in the center of granuloma. Okay, so if the common causes of neutrophilic microabscesses are not there, like dermatitis herpetiformis or psoriasis, but if botryomycosis is there, you can choose that as answer. Okay, so remember, here also small collections of neutrophils are seen in the center of granuloma, and this is not a fungal condition. This is a bacterial condition caused by Staph aureus. So next histological finding is acantholysis. Now what is acantholysis? It is separation of keratinocytes due to defect in desmosomes. Okay, so it is separation of keratinocytes due to defect in desmosomes. Now let us consider that these are two keratinocytes and both these are attached together via desmosomes. Okay, so these are two keratinocytes, both are attached via desmosomes. If there is defect in these desmosomes or desmosomal proteins, these keratinocytes will start separating. So this separation of keratinocytes due to defect in desmosomes is known as acantholysis. Now when acantholysis occurs, what happens when this keratinocytes separate from all the sides? It acquires oval shape. It appears something like this, oval in shape. Okay, most of the portion of this cell is occupied by the nucleus. Almost 7/8 portion. So 7/8 portion of the cell is occupied by the nucleus, and the cytoplasm is lying condensed at the periphery, giving, so this condensed cytoplasm gives perinuclear halo. Such type of cell is known as acanthocyte, also known as acantholytic cells. So such type of cells are seen due to acantholysis. These are known as acantholytic cells or acanthocytes, and these are the three characteristics of acanthocytes. They appear oval, they have large nucleus and perinuclear halo. Okay, so in one of the exams this question was asked that acanthocytes are which cells? They are neutrophils, eosinophils, lymphocytes. They are what? They are keratinocytes. So they are the same keratinocytes. The only thing is that their shape is changed. Now if you want to see these cells, you can prepare a smear that is known as zinc smear. Now when you prepare zinc smear, how we prepare zinc smear? So let us consider that this is a patient presenting with a blister. So if a patient presents with a blister, what you can do? You can simply rupture this blister and take the scraping from the base. Okay, with this scraping, you can prepare a slide, a smear, and stain it with Giemsa or Wright staining, and then see it under microscope. So this simple method is known as zinc smear. Okay, so what you are doing, you are rupturing the blister, taking the scraping from the base, preparing the smear, staining it with Giemsa or Wright staining, and then examining it under microscope. Now when you examine under microscope, you might find such acanthocytes, as I have told you. So if acanthocytes are seen, then it is suggestive of pemphigus. Instead, if you find multinucleated giant cells, it is suggestive of viral infection like herpes or chickenpox. If you find dyskeratotic keratinocytes, dyskeratotic keratinocytes, I told you D for D, so diarrhea disease. And if you find necrotic keratinocytes, then it is suggestive of epidermal necrosis. usually seen in 10 and Steven-Johnson syndrome. Already questions have been asked on pemphigus and herpes. So in pemphigus, acanthocytes are seen on zinc smear, and in herpes, multinucleated giant cells are seen. Okay. Now pemphigus is not the only condition where acantholysis occurs. Acantholysis can be seen in various conditions. So these are the examples of acantholysis. First one I already told you is pemphigus, like pemphigus vulgaris. Now along with this example, I will also tell you the reason why this separation occurs. So why the keratinocytes are separating. In pemphigus vulgaris, they are separating because there is defect in desmoglin. Okay. To be more specific, mainly desmoglin 3. In pemphigus foliaceus, desmoglin 1 is involved. In paraneoplastic pemphigus, plaquin group of family is involved, that is desmoplakin, placoglobin, envoplakin. So these are various desmosomal proteins which are involved in paraneoplastic. Then in Derriere disease and Halle-Halle disease, in both these conditions the defect is same, and that is defect is present in calcium ATPase. Then another condition known as subcorneal pustular dermatosis. Also known as Sneddon-Wilkinson disease. Here desmocolin is involved. So these are various conditions where these different proteins are involved, and since these proteins are desmosomal proteins, they are present in desmosome. So what happens when they become defective? The keratinocytes start separating, and because the keratinocytes are separating, the separation is within epidermis. So all these are which type of disorders? All these are intraepidermal disorders. Okay, so all these examples of acantholysis are intraepidermal disorders. So these are various examples of acantholysis. We have also written the disorders or the defects which are seen. Okay, so these defects are also important, like in vulgaris mainly desmoglin 3 is involved, in foliaceus desmoglin 1 is involved, in paraneoplastic desmoplakin, placoglobin, envoplakin is involved, Derriere disease and Halle-Halle disease calcium ATPase is involved, because I told you that desmosomal proteins are calcium dependent addition molecules. So when calcium ATPase is involved, again the desmosomal proteins get defective, and in this rare disorder, that is subcorneal pustular dermatosis, desmocolin is involved. So here you can see this is normal epidermis. In normal epidermis you can see these various layers, like here there is stratum basale which is having these columnar keratinocytes, then this is stratum spinosum where these hexagonal or polygonal cells are present, then gradually they are becoming flat spindle shaped. This is stratum granulosum, then stratum lucidum, and finally stratum corneum. Here the nucleus is present while here nucleus is absent. Okay, so this is normal epidermis, but when there is changes, these are known as abnormal changes or not abnormal histological findings which are seen. Like you can see this is parakeratosis. I told you what is parakeratosis. It is retention of nucleus in the topmost layer. So here let us try to understand. This is the junction, this is dermis, while this is epidermis. Here you can see these columnar cells are present, then these cells of stratum spinosum are present, and this topmost, this is the dead layer, that is stratum corneum. Now in stratum corneum, as you can see, nucleus is seen here, this dark bluish portion within the cells, this is nucleus, but normally nucleus is absent in stratum corneum, but here you can see this dark bluish portion is present. Okay, so this is what? This is parakeratosis. You can see the retention of nucleus in the topmost layer as well. Okay, so this is what? This is parakeratosis. Similarly, spongiosis, I told you. What is spongiosis? Extracellular accumulation of fluid in stratum spinosum. So again, you can try to see. So this is epidermis, below this is dermis. These are basal keratinocytes. Then above stratum basal, this is stratum spinosum. In stratum spinosum, you can see this nucleus is present, and stratum spinosum is almost intact here, but in this portion you can see that this portion is appearing white. Why? Because this is due to collection of fluid. So there is collection of fluid in between the cells. This is what? This is spongiosis, that is collection of fluid within stratum spinosum. So these are the histological findings which might be seen.